Good afternoon, good morning, good evening, depending on where you're joining us from. Thank you so much for joining this webinar today. This is a joint collaboration between WHO and Africa CDC, and this webinar is on Mpox case management. Today we are focusing on the overview of Mpox case management, and we are delighted that you are joining us this afternoon or this morning. Um, I I would like to welcome you all, and very happy to have you all in this webinar. I will be your moderator. My name is Dr. John Masina. I'm an emergency medicine physician. I'm part of the clinical case management team at WHO Afro. I'm based in Nairobi Hub. I have colleagues that are going to join me in this webinar, and I will introduce to them in due time. But thank you so much for joining us, and we're very delighted to have you, and we're looking forward for an active interaction service session in this webinar. So before I go and before we start or I go any further, I just want to remind everyone and to note that this virtual training webinar adheres to the code of conduct to prevent harassment, including sexual harassment, at any WHO event. I would also want to give you a few updates in terms of how we are going to conduct the session. We do have interpretations available for this webinar. So you can click on the interpretation icon on the toolbar on your screen, and the interpretations will be available in English, French, and Portuguese. And for the questions and chat, we do have the questions and answer section. This is where we would want you to use this facility for asking questions relating to the topic and relating to the presentations. And we are going to use the chat for the questions regarding IT, logistics, and/or certificates of attendance, which we are also going to post in the chat on all these aspects. And we are happy to have some chats around all the logistics in this section. I would also want to alert you that this session is being recorded, and your attendance is the consent to be recorded. And we are going to give a certificate of attendance, and this will be done through the University of New Mexico via the link that will be shared in the chat. So feel free to fill in, and then you will receive automatically the certificate of attendance for this session. I'd also want to alert you about the data usage. So Project Echo, that is supporting this webinar, will collect information on registration, participation, the question and answer, and chat comments. We do not have the poll responses, but we hope we can have the poll responses in the next sessions, but all that data will be collected. Okay, so at this point, I would want to just highlight a few lineup of topics and presenters that I have for today's webinar. I would straight away from here, I would turn to the opening remarks by Dr. Sam Boland. Dr. Sam Boland is the Incident Manager at WHO Afro region for the Mpox response. And then there straight we'll go to Mpox case management specific AP updates that will be given by Dr. Rashidatu. Dr. Rashidatu is a case management uh, medical officer at WHO Afro based in Dakar Hub. And then we're going to have the Mpox screening, triage, and isolation presentation by Dr. Carol. She's from Africa CDC. And we're going to have the case management overview by Dr. Jamie from WHO headquarters. And thereafter, we are going to have a Q&A session where we hope we're going to interact with everyone. And then we'll have the closing remarks by Professor Dembi from Africa CDC. Allow me to pause here for now and give the floor to Dr. Sam Boland, the Incident Manager for Mpox Response at WHO Afro, to give us some opening remarks. Over to you, Dr. Sam.
Thank you so much, Dr. John. Thank you as well to everyone on the call, including the interpreters. I know that it's very hard work to be sure that we can communicate such important information to those who need it. Good morning, good afternoon, depending on where you are in the world. As Dr. John so kindly introduced me, my name is Sam. I am the World Health Organization Regional Office for Africa Incident Manager for the Mpox response. I'm calling and speaking to you here from Brazzaville in the Republic of Congo, and it's really fantastic to welcome you to this discussion that we're having now. I'm really excited to see already such a wide representation in the audience from across the World Health Organization, but also critical partners, non-governmental organizations, and also ministries. Your participation is critical as we work together to ensure we can provide the most effective care for those affected by this outbreak. As you know, case management is really the heart of the response to Mpox. With regards to effective case management, it is essential, not only for saving lives, but also by doing so, building trust with communities and strengthening not only the overall response, but also our ability to deliver quality care, whether for Mpox or other issues in the future. Mpox is preventable and treatable, but can have severe consequences if not managed properly. Ensuring that health workers, but also caregivers and families, have the tools and knowledge they need to deliver proper care is fundamental. So providing this comprehensive guidance on treating of symptoms and screening ultimately serves to save lives and also to reduce transmission. Today's session, as John went over, will focus on sharing these insights and also updates on best practice in case management based on the evidence that we have so far in this response. These lessons learned, these protocols, and these procedures are absolutely critical to be sure that we can provide the best possible care according to the specific needs of different populations in different countries. By improving our case management strategies and interventions, we can not only help individuals recover more quickly, but also enhance community resilience, reduce the burden on health systems and focus on health service continuity, and ultimately contribute to controlling the outbreak. So I want to personally thank each of you, whether you are a frontline health worker, a policymaker, a representative of a partner organization, and everything in between, for your unwavering commitment to addressing this public health crisis. Your work is invaluable, and the discussions that will be had over the next hour and a half are absolutely critical for ensuring we deliver the best possible care for those affected by Mpox. So thank you again for being here on this call. I look forward to the important discussions ahead. I'll now pass back to Dr. John as chair, and again express my thanks and gratitude for the time you give to this important event today. Thank you very much, and Dr. John, back over to you.
Thank you so much, Dr. Sam. And I'm happy we can now move to the first presentation of the session. And this will be an overview on the epidemiological updates specific to case management. And this will be given by Dr. Rashidatu. Over to you, Dr. Rashidatu, and thank you so much.
Thank you very, very much, Dr. Maxina, and hello, everyone. Let me just repeat that my name is Rashidatu Fuad Kamara, and I'm supporting case management activities from the regional office in Africa, and I'm stationed at the Dakar Hub. So for us to be able to understand the clinical pathway to care, we'll need to understand the general picture of what's happening at the global level and also in our region. We'll have to take a look at the pattern of the disease distribution, looking at the trends, and that is what I am going to present on today. So basically what we've been seeing is a long tail of this outbreak. That is, it started in 2022, and most regions were affected. And as of today, we have a total of about 106,300 lab-confirmed cases, of which 234 people have died, and 123 countries are reporting. But I'd like for us to take a look at the trend on my right, and we'll see that the top bit is actually, the African region, and you'll see that there is a red box there, which emphasizes on the fact that our region is seeing an increase in cases. And this is followed by the West Pacific region, and then we have the Southeast Pacific region. The cases in Europe and EMERA, they seem to be declining, and also the Americas are no longer reporting cases. What we've observed is the fact that we're seeing an increase in cases from men who do have sex with men, and this is closely followed by people with co-infections, and then our healthcare workers are also being affected, and then people who do have travel history do come down with the infection, and the majority of the cases are also being sexually transmitted. So on the top, highlighted in red, is the fact that over 18,000 people do confirm sexual encounter, and that is how the disease is being spread. And then other forms of contact have been implicated. That is person to person, people who do come in contact with contaminated material, of course, unfortunately so, though the healthcare workers, and then animal to human transmission has also been observed. We also have few occupational exposures, parenteral transmission, and then mother to child transmission during pregnancy and at birth. On my right, I think I would like for us to look at this interesting pattern between the male and female transmission. And we'll see that in our region, that is the African region, there is close proportion between the men and the women in terms of acquisition of the infection. But then as we go further down, looking at the Eastern Mediterranean region, the European region, and going down, you'll notice that men are having the higher number of cases. This is not so in our region, and that is something that is really interesting for us to look at. So now, specific to our region, we are having an increase in cases, and so far we have reported 17 countries, and currently we have 14 countries that are currently in active response. So just to break down on what I discussed in the previous slide, we are looking at these 14 countries, and you're looking at the epidemic curves across the countries. That is the curves on my right. You'll see that we do have the DRC, we have Liberia, we have South Africa, etc., etc. But then interesting to note that we have newly affected countries from these countries on my right that had their first cases reported in 2024. And these include Burundi, Rwanda, Uganda, Kenya, Guinea, and Gabon. And then we had countries that had reported cases, but then they became re-affected. That is, they declared this Mpox outbreak sort of over, but then they actually started seeing cases again in this year. And these are Ivory Coast, Cote d'Ivoire, Liberia, Republic of Congo, and Cameroon. And then for countries that have been reporting throughout the years, that is from 2022, throughout this period up to date, we have CAR, Central African Republic, the Democratic Republic of Congo, Nigeria, and South Africa. So this slide is actually showing us the number of cases that have been reported, the deaths, and the cases in the last 4 weeks. I will not go in depth into all of this as the slides will be shared, but it will be interesting for you to take an or make an analysis of this slide. But what is crucial is to inform you that we are seeing the highest number of cases from the DRC, and that is followed by Burundi, and then Nigeria, Central African Republic, and then Cote d'Ivoire. So these are the 5 countries, or the first 5 countries that have the highest number of cases. And the same applies to the death. We're seeing increased death in DRC. So we all know that the Mpox virus, we have 2 clades in this disease, and that is the clade 1 and clade 2. And for these 2 clades, they also have subclades, the A and B. And so this is what we are seeing, the pattern of distribution of these clades in the various countries. And clade 1B, we are seeing in Cameroon, Congo, DRC, and Sudan. Sorry, clade 1A. And then clade 1B, we are seeing in Burundi, DRC, Kenya, Rwanda, and Uganda. And then we have the clade 2 countries, Benin, Cameroon, Ivory Coast, Egypt, Ghana, Morocco, Mozambique, Nigeria, and South Africa. So this is this is the pattern of distribution also of the clades, and DRC is reporting clade 1A and 1B. Nigeria has clade 2, A and B. Burundi, we are seeing clade 1B in Burundi. Ghana, clade 2A and B. Clade 1A. That's for the first 5 countries. You'll have an opportunity to look at this when the slides are shared. But then what is critical at this point is for us to know that the West Central Africa sub-region is reporting most of the cases. About 99% of those cases are from the West Central Africa sub-region, and also the deaths. Most of them are coming also from the sub-region. So this is the epicurve and the pattern of distribution, the map of Africa, and where the cases are coming from. You'll see the yellow and the red circles. The yellow represent the cases, and then the red, the deaths. And you'll see that the biggest circles in terms of cases and also death are from the DRC. So what have we done as a region? I'm sure you all are aware of the Continental IMST. That is the collaboration between Africa's CDC, WHO, and other partners to set up this very important IMST according to the Emergency Response Framework. And that has been set up so as to have effective coordination in the various countries. And a joint strategic preparedness and response plan has been developed and alongside the interaction plan. And this has been disseminated to all key stakeholders to support coordination, collaboration, and also guide resource mobilization activities for this critical response. So the IMST, we have various pillars, and there's been engagement from all these pillars. We've had weekly meetings with country offices and also between the other partners, that is WHO, Africa, CDC, and all the other partners. We've had surveillance intensified, the data reporting and dissemination of situational reports are ongoing. We've had the activation of the AAM, which is part of the Inter-Medical Countermeasure Network, and that is for countries to be able to access vaccines and other therapeutics. And there's continuous capacity building, and currently some guidelines have been reviewed, especially for case management. And the laboratory counterparts are also increasing access to their diagnostics. And we have those talking points that are being disseminated on a weekly basis so that the public is aware of the ongoing situation. And we have also started the WHO Global Dashboard for Africa. So now the key take-home message from my presentation is for us all to be aware of the situation, and that is the fact that the cases in our region are increasing. And so far we have 17 countries. Back in 2022, we had only 11 countries reporting, and it was not as amplified. That is, the number of cases was not as large as this one. But now we have increased cases, and 14 countries in our region are currently active. The drivers of transmission, as we have seen, is primarily through sexual intercourse and other forms of contact. We didn't mention this in the previous slides, but we need to be able to understand that children are also being infected. In our region, we are seeing almost an equal pattern of distribution between the males and the females. And what we need to do moving forward is for countries that are sharing borders with countries in response to be very vigilant and to escalate preparedness and readiness activities as guided by the SPRP, which has been shared to all. And also for WHO, CDC, and partners, we have continued to strengthen coordination and collaboration for the response in active countries so that we'll be able to mitigate this transmission and to scale up access to vaccines and therapeutics. I thank you all for listening. This is my last slide.
Thank you so much, Dr. Rashida, as ever, clear and very well presented data there. So, colleagues, we have the Mpox declared as a public health emergency of international concern by the WHO Director General, and also a public health emergency of continental security by His Excellency the DG of Africa, CDC. And this is why this team is assembled here to look at how we can manage this situation. Already we understand that we've got 14 countries in active response as we speak, and we do have about 34 mortalities in 2024 alone. These are confirmed, and then we have about 152 suspected and confirmed mortalities in the last couple of weeks or months. So this is actually an important event that we need to sit and look at how best we handle this response. And having this background of the numbers and the countries involved, and also the declaration of this event of being of international concern, we have to talk about how are we going to identify these cases, how are we going to screen in terms of triaging these cases as well, and how are we going to isolate these cases safely, and this will help in curbing around the transmission. So to do that, I'm going to welcome Dr. Caro from Africa CDC to give us a presentation on Mpox screening, triage, and isolation. Thank you so much, and over to you, Dr. Caro. Caro?
Oui, merci. J'essaye de faire le partage. D'accord, c'est visible maintenant?
Just put it in slideshow.
Bonjour à tous, je suis le docteur Carole Boimbo. Je suis dans l'équipe d'appui à la gestion des cas de Mpox pour le compte du Centre de coordination régionale de CDC d'Africa CDC pour l'Afrique centrale. Donc, je vais parler du dépistage et du triage qu'on fait dans le cadre de cette gestion de cas de Mpox. Notre objectif, on va revenir brièvement un peu sur la transmission, les signes et symptômes pour pouvoir identifier les cas puisque c'est l'important, c'est la base même pour le dépistage. Ensuite, nous allons essayer de comprendre l'objectif et les bien fondés de faire un dépistage, un triage, expliquer également les méthodes de triage, de dépistage et de triage et les principes même de l'isolation, de l'isolement. Donc, juste en rappel, c'est, je crois, docteur Rachida en a parlé, c'est une maladie, le Mpox, c'est une maladie causée par le Mpox virus et qui se caractérise par une éruption cutanée. Souvent, elle est de guérison spontanée, mais elle peut évoluer sur des cas sévères et voire la mort. Et les cas même peuvent aller jusqu'à 11%. On peut même aller jusqu'à 11% des décès. Et généralement, c'est les enfants qui sont le plus touchés par ces décès. En rappel, pour les modes de transmission, on en a plusieurs. Initialement, nous savons que c'était une zoonose dont la transmission primaire humaine de l'animal à l'homme se faisait soit par contact direct, soit par contact indirect avec à cause d'une morsure avec d'un animal infecté, des égratignures ou bien durant la manipulation d'un animal infecté lors de la chasse, de la préparation de cet animal. Et le fait de manger certains animaux nous expose également, qui sont les primates non humains, les rongeurs, les antilopes, les gazelles, chez qui on a pu retrouver le Mpox. Concernant cette transmission d'homme à homme, on a vu les statistiques tout à l'heure avec docteur Rachidatou. Il y a des risques de transmission lors d'un contact direct ou indirect, et fait également. Lors d'un contact direct avec une peau infectée ou une muqueuse infectée, des lésions muqueuses infectées, ou lors d'un contact rapproché prolongé, ce qui nous expose à des gouttelettes respiratoires. De manière indirecte, c'est lorsqu'on est en contact avec les objets personnels d'un malade infecté, notamment ses habits, son linge et autres, ou bien même des surfaces qui ont pu être contaminées, d'où l'importance de mettre en place un bon système de dépistage pour éviter de contaminer l'environnement où des malades non Mpox peuvent se retrouver, et également même quand en communauté, lors de la prise en charge communautaire dont va parler docteur John. La période d'incubation et comment est-ce que la maladie évolue? C'est généralement 6 à 13 jours la durée de la maladie dès l'infection jusqu'à l'apparition des premiers signes. Mais ça peut aller jusqu'à 3 semaines, notamment 21 jours. Et il y a généralement deux phases. Il y a d'abord la phase invasive qu'on connaît avec les éruptions, avec les symptômes pseudopalustres, dont la fièvre, les maux de tête, les lymphadenopathies, c'est important de le retenir, les lombalgies, les
Back
aspérités.
pain,
Et elle dure généralement
migraines, and
0 à
fatigue.
5 jours. Et
And
ensuite
most of the time,
vient
this period
l'éruption
is from
cutanée,
0
généralement
to
1
5
à
days. And
3
then
jours
you
après
move on
le
to
début
the
de la
rash.
fièvre.
The
L'éruption
rash
cutanée peut se
appears
manifester et elle
right at the
commence
beginning of the
généralement au niveau du
fever. And
visage
most of
et
the
avant de
time, it
s'étendre au niveau
starts
du
on
tronc et
your
des membres.
face, then moves on to your bust and
L'extension,
your limbs.
généralement,
Limb.
se fait, généralement, on
Most
peut
of the
avoir
time,
une
the extension and
lymphadenopathies,
duration of
une maladie
illness
lymphatique
can be
et
done
qui se développe, comme
can
on l'a dit tout
start
à l'heure, lors de
with
la
a
phase invasive.
severe
Et le
lymphadenopathy.
mpox peut
As we
durer
said,
jusqu'à
this
4
is the
semaines, donc
first
3 à 4
symptom.
semaines.
And now,
Et
mpox usually
les
lasts
enfants
from
sont les
3
plus
to
touchés
4
par
weeks,
les cas
and
sévères.
children are the most affected by severe disease,
Quelle est
as
la
it has already been
caractéristique
mentioned.
de
What
l'éruption
are the
cutanée au niveau du
characteristics of
mpox?
the rash
C'est
and
que
its
ce sont des
evolution?
lésions
We
évolutives.
know
Elles
that
évoluent
these are
ensemble. Ça commence d'abord par des
evolving
macules, c'est-à-dire
lesions.
édémateuses.
They'll
Ensuite,
start
les
as
papules installées. Ces
macles
lésions
and then
étirées
become papules
jusqu'au
to
VA.
some
Ensuite, les
extent
vésicules.
and
Donc,
move
on a
on
du
to
fluide
becoming
clair à
vesicles where
l'intérieur
you
de ces
have a
boutons.
clear
Ensuite,
fluid,
on évolue
and
vers les
then
pustules
you move forward to the formation
et
of
enfin
pustules,
vers les croûtes.
which
Et
has
comment est-ce
yellowish
que ça
fluid,
se
and finally
répartit?
it becomes crust.
95% des
How
cas qu'on a
does it
pu
affect
répertorier
the body?
ont des lésions
In
faciales.
95%
Les
of the
paumes des mains
cases,
et
you
des
have
pieds sont
lesions
également
on the face,
caractéristiques parce que
and then
75%
the
des cas de
palms
nos
and
cas
the
l'ont
soles
eu
of
et
the feet
majoritairement c'est 70%
are also
avec des lésions
affected. 75
aux
people
des
of cases
muqueuses
have shown that
buccales. Moins
symptoms.
avec des
Also,
lésions génitales,
70,
30% et c'est pas
70%
exclu. Et
have
même
shown
au niveau des
lesions
atteintes
at the
cornéennes
level
et
of the
conjonctivales,
oral
c'est
mucous
également revenu, mais à 20%
membranes.
des cas.
And then we have
Et
30% for
ces
the
lésions-là, parfois, elles
genitalia
peuvent être
and
isolées,
20% for
parfois, elles peuvent
uh,
être minimes,
the
parfois,
conjunctiva
elles peuvent
and
être
cornea. Don't
multiples. Donc,
forget that
ne nous
those
attendons pas
lesions
toujours
could be
à des
few,
lésions
but they
multiples
could
comme on le
also
voit
be
sur la
several
photo à
thousand.
droite.
So do not
Et
always
les
look up
croûtes peuvent
to
mettre
have a
3
lot of
à 4
lesions. They can
semaines
be
pour
quite small
disparaître
in
également.
number. And also those
Là,
crusts can
regardons un
take
peu le
3
type de
to
lésion et
4
selon
weeks before
le
disappearing.
niveau ou le stade
Now,
de la
let
maladie.
us look at
Quand
the
on est au
active
début de la
lesions,
maladie, en fait, on a
depending
des
on the
lésions très
stage
petites
of
d'1
this
à 3
disease.
millimètres.
At
Elles
the
sont
beginning,
soit,
you
comme on
have
l'a dit, des
small
macules, des
lesions
papules, des
from 1 to
vésicules,
3
voire des
millimeters.
pustules.
As I said
Mais dans
already,
la
they are
progression, comme on le voit dans
solid
la photo
maple,
supérieure à
purple
gauche, mais
vesicles.
dans la
And you can
progression,
see
on
that in
évolue
the
plutôt
picture
vers
on
des
your left.
croûtes.
But as
Donc, une
the sickness
ombilication des
evolves,
lésions et des
you move
croûtes, comme on le voit
towards
sur
the
la
formation
phase,
of
la
crust.
photo
And
au
you can
milieu à
see
gauche.
that in the
Et
picture,
enfin, un
the
peu
second
plus
picture.
avancé, c'est
And
là où
then
on peut
when you get
avoir
to the
des
late stage,
ulcérations, parfois
this
même
is
des
where you can
escarres.
have ulcer with purulent base, as you can see in the last picture on your left. It is very important to talk about the crust stage. Those crusts could be yellowish, or they can cause bleeding. They can be hemorrhagic crust. I hope that
And
the
also
pictures
be an
are
escar. I
clearly
think you can see the
visible.
pictures on the upper part of the slide. When we see the crusted lesions, we think the infectious phase is over. It's not the case for mpox. Crusts of scabs remain infectious. When we don't have a new layer of skin, we should consider the crust as infectious. It's important for us to talk about differential diagnosis. This is a rash illness. We have varicella, chickenpox, measles, and smallpox, which is now eradicated. But we should not rule out other conditions like bacterial skin infections, scabies, syphilis, and severe medication or severe allergies. We should consider other febrile illnesses as well. It's important to have a laboratory confirmation screening for Mpox. This is a table which compares Mpox, chickenpox, and measles. For symptoms, you have fever. There's not much of a difference. 1 to 3 days, 1 to 2 days, 3 to 5 days before the symptoms appearance. Foreskin rashes, lesions are generally at the same stage of development. Skin lesions at the same stage, either we have either maculas, papulas, or scabs for Mpox, chickenpox, or measles. But for chickenpox and measles, we can have vesicles here, papulas there, and we have multiple stages of development. Now, for the rash development, the development is rather slow for Mpox, which is not the case for chickenpox and measles. Rash distribution should be known. It is important. Mpox has a more dense sores on the face. 70% of people have sores on palms and soles, which is not the case for chickenpox, which is more dense on trunk, absent on palms and soles. Measles starts on the face and spreads, reaching hands and feet. Lymphadenopathy is also a feature. It is present for Mpox, but absent for chickenpox, and at times for measles. The CFR rate varies to up to 10%. Given that it is a mild disease, CFR is case fatality ratio is rare and depends on underlying conditions. In epidemiology, we work with case definitions. These are definitions that are standardized so that in the north, south, or center region, we all know how to identify a suspected case, a probable case, and a confirmed case. WHO suggested definitions that are adapted locally by the country. We're now going to see the definition of suspected case. There are two trends. Either it is a person who is in a contact of a probable or confirmed Mpox cases in the 21 days before the onset of signs and symptoms, on which present and who presents any of the following: acute onset of fever, headache, myalgia, back pain, profound weakness or fatigue, or a person presenting with an unexplained acute skin rash, mucosal lesions, or lymphadenopathy. The skin rash can include single or multiple lesions in the anogenital region. Mucosal lesions may also include single or multiple oral, conjunctival, urethral, penile, vaginal, or anorectal lesions. Anorectal lesions can also manifest as anorectal inflammation, pain, and bleeding. So either it is one of the two case scenarios, or a person for which the following common causes of acute rash or skin lesions do not fully explain the clinical picture: varicella zoster, herpes zoster, measles, herpes simplex, impetigo, bacterial skin, I will not cite them all, birds, or we don't need to find causes for other diseases before we can define a suspected case. Because by the time the patient goes through all the pathway of diagnosis, he or she can infect other people. So when we have a confirmed diagnosis for chickenpox and other conditions, if we have an epidemiological context of contacts with other people, we should have ourselves screened for Mpox because co-infections have been diagnosed among patients. Probable cases are very simple. This is a person presenting with an unexplained acute skin rash. It is a suspected case, which additionally in the first four bullets are suspected cases with an epidemiological link to a probable or confirmed case of Mpox in the 21 days before symptom onset, or has a multiple casual sex partners in the 21 days before symptom onset, or has a positive test result for orthopox virus, but no screening has been done. Confirmed case is a person with lab-confirmed MPXV infection by detection of viral DNA by PCR. We also have a community case definition. The community needs to be aware and cannot be submitted to a very technical definition. So for community case definition, it is a person with an unexplained recently appearing skin rash or swollen lymph nodes. Even if it's a single skin rash or multiple lesions in the genital region, including mouth and eyes. Why do we perform screening generally? What is screening, first of all? Screening is a process by which an individual is evaluated to see if he meets the case definition. We have seen the case definition, suspected cases. Does this person meet the definition of a suspected case? So whatever the technical platform at your disposal, whether at the primary health care center or at the referral level, it is important to perform screening. Why screening? Screening is done to allow for early detection of suspect cases before contamination. It also helps to minimize contamination. This should be followed by triage and isolation of suspected cases. We are going to see the distances that should be observed between the patient and the healthcare worker performing screening. When and where should it be done? Generally, it is in emergency unit, the first point of contact with patients in outpatient departments, primary care clinic, mobile health centers, and even by telemedicine. We want to standardize the process, the way by which screening is being done in the north, in the center, in the south should be identical. Procedures should be standardized. Health facilities should standardize questionnaires. You can use a checklist, ask questions, or do it verbally. Now, what is triage? Triage is sorting, a process of sorting patients into categories based on their vital needs. Why triage? Triage helps to identify patients. When we have a cohort of patients, we can identify those who require immediate medical intervention and those who can actually safely wait for an intervention. Where is triage done? It should be done in the emergency department or at the entrance of the health facility. Screening and triage are important to protect yourself, healthcare workers, to protect also your patients visiting for one or any other disease, protecting your family and your community as well, because if we become infected, we bring the infection to the community, and in the front line are our families. How do we set up a screening and triage area? First of all, we need an adequate space so that the screening and the triage will be done safely for the staff performing screening, safely for the patient being screened. There should be a distance of 1 meter, a 1 meter distance between various staff. We should also have hand hygiene, as during COVID, we need PPEs, masks, gloves, eye protection. We need gowns to be used. We need to set up a waiting room. There should be at least 1 meter apart for the various patients, because we will have suspected cases of Mpox and others that will not be suspected. So they should not be mixed up. They should not be cohorted. We also need just a one-way flow for patients and for staff. It's important that this area have clear signage posted, so that any person going through the triage area can bring to his community relevant information. So we should avoid having family members and as well as overcrowded areas. Screening for Mpox is being done with the case definition, screening for rash and fever or lymphadenopathy, or according to the locally adapted WHO case definition. Secondly, once a patient is a suspected case, according to the case definition, he or she enters the clinical care pathway. But this pathway should be actually standardized. It has to be given medical masks, sanitizer, and he or she should be put in isolated in a well-ventilated single room. We should avoid air-conditioned ventilation. Natural ventilation is much better, but if it is not possible to put the person in a single ventilated room, we should group patients with similar clinical diagnosis together, observing the 1 meter distance. Now let's talk about isolation. Isolation is the separation of the suspected or confirmed to be infected with a contagious disease from those who are not infected. So we should not cohort them. We should isolate those who are suspected from those who are confirmed to be infected. The principles are those. Once a patient has been screened, once triage has been performed and the patient is identified as a suspected case, it should be separated, isolated from non-suspect patients. We should not cohort suspected cases with confirmed cases. We have lost the speaker. Isolation is the ideal strategy. With COVID, we experimented it. We need to find an isolation room if we don't have one yet. So what are the isolation area and room requirements? First of all, the isolation room, it should be left for suspected cases or patients only. It should have a unique exit or be close to its own exit, so that the suspected patients will not cross the whole hospital area, because if he's suspected, he can actually contaminate the environment or the patients and the staff himself. We should maintain a minimum of 1 meter between patients, though in isolation, we need a single well-ventilated room. The ideal will be to have a negative pressure room, but if we don't have that, a well-ventilated space will do. We need minimum material available. We need washable material that can be disinfected, like plastic chairs. We should not crowd the room with items that cannot be disinfected. We need dedicated latrines or toilets. We know that the virus can survive a few days. So if we mix these patients with others, they can be contaminated while performing the personal hygiene. How do we isolate patients with suspected or confirmed Mpox? Suspected cases should be placed in well-ventilated single room with dedicated toilet and latrines. They need individual bedpan dedicated for themselves only, as it was done during COVID. We should not mix up suspected patients with confirmed Mpox patients. Now, for confirmed Mpox cases, we should highlight it once more. We need a negative pressure room so as to reduce risks of infectious particles being circulated in the environment. So these patients should be put in isolated, dedicated room. To finish, let's talk about personal protective equipment that you need to use during health and care for suspected or confirmed Mpox patients. You need to wear gloves, gowns, masks, eye protection, respirators. You need to wear footwear that can be decontaminated, like boots. Disposable shoe covers are not recommended. It's therefore important to be trained to avoid being contaminated while removing PPEs. Thank you for your kind attention.
Thank you so much, Dr. Caro. And I hope we are not having the mix-up in terms of interpretation. Please just go to the interpretation icon and click the preferable language. There will be some interchange of languages, especially when we come to discussion, but this is all to cater for Francophone, Lusophones, and the English-speaking countries. So I'm happy if we are able to interchange between the languages, and we want to cater as many as possible. Thank you so much, Dr. Caro. And just to emphasize, I think the points on screening, which is the identification of the suspected cases, and also the triage in terms of sorting and identification of immediate medical needs of this patient, and also highlighting the needs for isolation in this aspect in terms of keeping off the transmission of the disease. And I think now that we have the background of how many cases we have and how many countries are infected, how many countries are affected, and also now having the background of how do we identify these cases, and having the background of how do we identify who needs to be managed, I think it's high time now we look at how are we going to manage these cases. And I'm very honored and happy to welcome my supervisor and someone that I'm learning from every day. I want to welcome Dr. Janet Diaz. She is the team lead for the case management at WHO headquarters in Geneva, and she's going to give us their overview of case management of Mpox cases. Over to you, Dr. Diaz. Five out of five.
All the colleagues for putting this together. This is really a team effort to get this webinar series going, and it is my pleasure to present on behalf of a much bigger team that's responsible for the clinical case management for Mpox and other emerging infectious diseases. I will close my camera because my internet is a little bit weak, and I want to make sure you can hear me. So before I start, I just want to echo what was previously said about the importance of doing safe, quality clinical care for patients with Mpox. And really now it's really to go back to the basics. So what I'm going to provide you with is an overview of case management and clinical care in a very brief manner, but hopefully you'll get three main messages. One message is to be systematic in the way you approach patients. This is not different than any other clinical disease you manage. So be very systematic in the way you approach, just as was described, screening, triage, clinical assessment, and choosing the right treatments for the right patients. Be very systematic in the way you approach the supportive care, so you know what the complications are and you can treat those appropriately. And be very systematic in the holistic, comprehensive approach to care. So it's also medical care, it's psychosocial care, and nutrition care, and special care for vulnerable populations. So if you remember these kind of three major areas, this is the way we would suggest you approach care for patients with Mpox. So next slide, please. Here again is just some important management steps. As you've heard from the epidemiology, we have seen transmission amongst through sexual contact in addition to direct contact. So of course, with those patients, also check for other sexually transmitted infections. As you've heard already, skin lesions are one of the major manifestations. So obviously good care of skin is very important, and any complications that can arise from that. Pain management is key. Good pain management can keep patients out of the hospital, but sometimes pain management is one of the most important reasons patients do get admitted to a hospital. Infection prevention and control, that is a huge topic, and we'll probably have another webinar on that. But of course, that is key to prevent nosocomial transmission between patients and other patients in the facility, as well as between patients and health workers. And of course, as I've said before, good supportive care. And someday, hopefully, we will have effective antivirals for patients, but at this point, there's no proven effective antiviral for Mpox. Next slide. Here is just a simple schematic of some of the three important areas. So one is to consider strategically, the treatment center design. So where are you isolating your patients? What are the wards looking like? And it's important that these ensure that you can deliver the IPC intervention, as was already described, with a gown, gloves, mask, eye protection as required, and appropriate donning and doffing between patients so that you don't cross-contaminate between patients. Remember, this is an area that should be able to deliver medical, nutrition, and mental health care, and also be available for patients and family-friendly and for staff and communities. The next area is about optimized supportive care. And I'm going to talk a little bit later about the PALM 007 clinical trial that completed recently in the Democratic Republic of Congo. And what we learned from that trial is the importance of optimizing your supportive care, which means systematic assessment of patients, which means good skin care, which means resuscitation with oral or IV fluids if there is evidence of dehydration. And then finally, the specific therapeutics. As I said before, there is no proven effective therapeutic for Mpox. There are ongoing trials that are evaluating tecovirimat. And again, I will speak about the results of the PALM 007 trial a little bit later, but there are two other ongoing trials still evaluating its efficacy and safety. Next slide. I like this slide. This is really giving you a little bit of the Mpox clinical care pathway, which was already discussed a little bit by the previous speaker. Always start with the screening of cases, screening of patients on arrival to the health facility or to the health point, and then you can do an assessment for a suspected case. Regardless, you always need to do triage of patients, meaning that you do need to do, as you triage all other patients, signs of severity, see if there's any emergencies requiring emergent interventions, and then do a clinical assessment and diagnostic testing. Now, you will have a decision to decide whether or not a patient with suspected or confirmed Mpox gets treated at home or gets admitted to the hospital. And this really does depend on the local care pathway strategies. Some countries are choosing to hospitalize everyone, and so that they can control and make sure that good isolation is done in a health facility. But other countries have chosen to do home care when that can be done safely. That is also another option, as long as we can do it safely. So what does that mean? At the top, you can see the considerations for home care guidance, and this will be a publication soon by the WHO, we hope in the next week or two. So good patients to consider home care are patients who do not have severe disease, so patients who are mild, are clinically stable and have no complications, and also patients who are not from high-risk groups. This means high-risk patients include pregnant persons, children under 5 years old, and patients who are immunosuppressed or have malnutrition. So consider home care in patients who are not severe and not at high risk. And also, you must consider the capacity to do home care at home. Is it feasible? Are you able to actually properly isolate a patient at home? Can you ensure that the infection prevention and control measures are in place? And is there a mechanism for daily follow-up? And this is a daily follow-up, and it can be a remote or virtual daily follow-up, or in some cases, a home daily follow-up. And then, of course, that's when you can consider home care. And for other patients, obviously, facility-based care in the hospital, that's for sure if someone has complications or from high risk, and then follow-up patients till discharge. And after discharge from care does not mean that care stops. Actually, follow-up after discharge is important still to make sure that patients don't develop any medium or long-term sequelae. Next slide. Here's just a simple example of a triage systems. I'm not going to go into this in detail, as many of these standardized triage tools exist, but really it's important to make sure that patients, if they have any emergency signs of airway, breathing, or circulation, that those get treated immediately and do not get delayed because the patients in the Mpox clinical care pathway, they still need to get the ABC treatments done safely. And here's another slide for the ABCs. That everyone is well aware of. And here, just make sure for the Mpox patients that you properly look at all the skin lesions, especially not just, on the face, on the arms, on the skins, on the hands, in the chest, and in the anogenital area as well as in the oral area and the eyes. And then look for other systemic issues around hydration, which I do want to focus on, and nutritional status. Next slide. Once you've done the clinical assessment, it is important to continue to reevaluate your patient. So doing the disease severity classification is important. Even though our classification system is an old one, we haven't updated it. But we do know that some of these things are associated with worse outcomes, such as patients who have numerous lesions. So it is important to count the lesions and look at the evolution of the lesions. Intractable pain is a sign of severity. And any complication of organ dysfunction, so that would include organs such as your eyes, organs such as your brain, so mental status changes, encephalitis, meningitis, organs such as your cardiovascular system or your pulmonary system, so shortness of breath, chest pain, trouble breathing, and then any other complex lesion in the urogenital tract that can be interfering with urination, or the perirectal area that can be impairing defecation, and any lesions that may be interfering with swallowing and breathing. And then depending on the disease severity, then you need to monitor your patients. So if the patient has signs of severity, you will need to put them in some sort of higher dependency unit or an intensive care unit where you can monitor them frequently. In some cases, maybe every 30 minutes or an hour if you're doing resuscitation. In other cases, once they're stable, maybe monitoring every 4 to 6 hours. And in cases that are mild, that may be cared for even at home once a day or every 12 hours. And testing, not just Mpox testing. So it is important to confirm the diagnosis of Mpox, hopefully if you have sufficient laboratory capacity, but as well for patients that are hospitalized. Remember, Mpox is not circulating in isolation. If you're somewhere where there's malaria common and the patient has a fever, obviously test and treat for malaria and other local pathogens. And also for those that are more complex, that are more severe, that look malnourished, that have dehydration, that have not been eating, remember to check electrolytes, to look for the creatinine function, to look at the glucose function, to look at the hemoglobin, and to understand better if there are other metabolic complications associated with your patient. And on the schematics to the right, you can just really see, you don't need very fancy materials, but you need to make sure you have a blood glucose monitor, you are able to count the respiratory rate, you're able to check the saturation, the temperature, and the blood pressure. And all these things that you use, make sure that you apply appropriate infection prevention and control to make sure that these are either for patient use, independent patient use, or if you're using them between patients, that you need to clean and disinfect them appropriately. Next slide. So quickly, just to go over some of the highlights, management of pain. This is a common problem in patients who are hospitalized. But remember, do the basics well. You know about managing pain with paracetamol that is widely available for adults and children. In some cases, you can add on a nonsteroidal anti-inflammatory. In other cases, you can add on tramadol. These are all oral medicines. And obviously for very severe cases in patients who are in the hospital, the use of analgesia with morphine or other narcotic-based analgesics can be used under close supervision. And then if you do have complicated lesions such as proctitis, those things that were in the last slide, just consider laxatives to ensure that we have a good stool movement in patients. Next slide. So here, management of skin lesions. Skin lesions, as the previous speaker described, can be on the face, they can be in the eyes, they can be all over, like you see here, all over the chest, and very extensive, as well as in the anogenital areas. It is important to clean the lesions. So I think number one is good skin hygiene, to keep them clean, to use soap and water. It could be sometimes necessary to use antiseptic solution when it is required. Next bullet. When possible, now, keeping the lesions open and exposed to air can help them heal as well. So you don't need to keep them all covered. However, if you are going to be moving around with your lesions, or the patient has to move somewhere and maybe close to other patients, it would be important to cover the lesions. Here's another important point: is do not give prophylactic antibiotics. So there is no evidence, well, there's very little evidence generation happening right now, meaning clinical trials on the best approach to care for Mpox. But for good antibiotic stewardship, we do not recommend using prophylactic antibiotics. However, if you do see signs of superinfection of a local cellulitis, then you may consider antibiotics, either topical or oral antibiotics. And in managing the skin lesions, remember, patients who may have extensive skin lesions, especially small children, they can put themselves at risk for dehydration, especially if they're not drinking. So really important to look at the hydration status, especially with people who have extensive skin lesions, and make sure that they receive appropriate hydration. Next slide. Secondary skin infections. WHO does have the AWARE handbook for empiric antibiotics for different types of infections. So this, again, is if you feel there are secondary skin infections from bacteria on top of the Mpox, and maybe the signs of that would be increased local pain, swelling, edema, redness. There you can consider giving oral antibiotics depending on the extent of the antibiotics, and this AWARE handbook gives you some recommendations for what can be used. Next slide. Eye complications. This is another important one. We have been, the actual prevalence of eye complication varies in different publications. So I think it's something still we need to carefully monitor and see how often these complications are happening, or if they're happening more often in different age groups or with different clades. But for now, we have observed it, and it has been observed now in the current outbreak in the Democratic Republic of Congo. And it's important to do eye exams systematically in your patients to look for redness, conjunctivitis, keratitis, uveitis. And then the treatment, I really would say, please consult an ophthalmologist. This is a specialty care. Where not the best approach to care may be some topical antibiotics. There's also some generic and broad spectrum antivirals that have been used. And in some cases, specialists may choose to use topical steroids. But again, I think here the recommendation is to really consult your ophthalmologist and have someone take a good look to make sure that we prevent any serious problems with vision or loss of vision in the long term, which is what our aim is. And then from the IPC perspective, please counsel your patients. I know they will want to touch their eyes and then touch something else, but the eye is infectious. So make sure that IPC precautions are used when evaluating the eye, as well as for the patient not to rub the eye too much and then start touching other items. Next slide. Feeding, nutrition, hydration is really important. When we're seeing different age groups affected with Mpox, so that I would like to highlight this in all the age groups, and especially in small children and young children. Malnutrition may be a risk factor for severe disease, so treating malnutrition if food is there is also important. Conditions such as mucosal lesions in the oral mucosa or in the pharyngeal may actually limit intake of food, and this could also impair the hydration. So again, just keeping a good eye and using appropriate hydration protocols for patients. Next slide. The next few slides are really just a table of items for symptomatic care. The treatment of fever is important. The treatment of pruritus is important. Next slide. Exfoliation skin compromise. If the skin becomes quite complicated here and you're not sure if it's secondary infection or how much exfoliation is happening, then it is important to consider a specialist evaluation with a dermatologist, someone that can help you make the best treatment package for the patients with complex skin lesions. And this, I think, it will be one topic of a webinar, is really getting deep into the skin care for patients with Mpox. Eye infection, I've already spoke about. And then here is just, again, a few other tidbits around mouth and sores, which I already spoke about dehydration and vomiting and diarrhea in case the patient has those symptoms. Lymphadenopathy, this probably merits a little bit more discussion, but and we'll do that in one of the future webinars, but really looking at lymphadenopathy in the cervical area, which has been reported to compromise airway function in some patients. So really making sure that if there is cervical lymphadenopathy, that the airway, not making sure the airway is painted and the patient is breathing okay. And in some cases that can be very painful lymphadenopathy, so good pain control. And some specialists may choose to use anti-inflammatory medicines if the lymphadenopathy is obstructive. Again, there can be signs of sepsis with organ dysfunction such as respiratory distress and septic shock. And those two conditions need to be treated accordingly to sepsis protocols. In regards to therapeutics, as I've said a couple of times, there is no proven effective therapeutic for Mpox at this time. And in view of the lack of evidence, WHO recommends that antivirals should be used under randomized controlled trials with collection of standardized data to increase evidence generation on efficacy and safety. And if this is not possible, antivirals may be used under expanded access protocols, such as MIRI, the monitored emergency use of unregistered and investigational interventions. And WHO does have a program for this, for tecovirimat. Next slide. And here is what I mentioned before, but also now to give it more space. The PALM-007 study is a study that was conducted in the Democratic Republic of Congo by the National Biomedical Research Institute, the INRB, and the NIH from the United States. They studied tecovirimat in clade 1 disease, and they recently reported their results. We don't have the full results, but their preliminary results that there was no effect on the primary endpoint to skin lesion resolution. So there was no difference between the two treatment groups. So this suggests potentially that this tecovirimat is not effective, although we are waiting to see the full results in order to make our full conclusions. However, both groups in this trial had a mortality of 1.7%, which is less than the historical mortality reported in the Democratic Republic of Congo, which has been consistently higher. And what that does suggest is that they did implement as well a standardized supportive care treatment protocol, so just to do the basics well, and that in itself probably reduced the mortality in this patient population. There are ongoing tecovirimat trials in clade 2, and those include STOMP and UNITY, which are ongoing in multiple countries, including Geneva, Brazil, the USA, and some others. And we are working to understand those results when they become available to update our recommendations. And if you want to look for the therapeutic pipeline, you can look at the website of the R&D Blueprint, where they frequently update this list of landscape therapeutics for Mpox. Finally, a few more slides on nutritional support. Assess nutritional status of all patients. It's really important. Assist with feeding. So food should become available to patients who are hospitalized in the facility, and also those that are being taken care of at home. And consider a nutritionist or a dietitian specialist evaluation when necessary. Next slide. Remember to have specific adapted protocols for small children, including neonates, infants, and children. Neonatal sepsis, can be common in some areas, and if you have neonatal sepsis as well as Mpox, the care of that patient can be very complex. So make sure that your protocols and your diagnostics are available to best care for those patients. Pregnant women, also make sure that any pregnant woman who is admitted with Mpox gets the normal care that she would get for her pregnancy, and good counseling and follow-up. Patients with HIV, also evaluation for starting of antiretroviral therapy is important, and we'll have other webinar that will focus on that. And of course, patients who are sexually active, screening for other STIs and treatment is important. So psychological support, again, this is part of mental health and psychosocial support, which should be available to all Mpox patients. Next slide. And contact tracing. I'm not going to talk about this too much. This is more for the surveillance teams that should be present at the Mpox treatment facilities or in the home care situation. That contacts should be traced, should be monitored and counseled for symptoms of Mpox. So in conclusion, in the absence of conclusive clinical efficacy trials, management of Mpox is mainly supportive and symptomatic. So again, symptomatic, supportive, but be systematic in your approach to this. Holistic care of Mpox requires a multidisciplinary team, and in some cases will require a specialist in infectious disease, dermatology, wound care, mental health, ophthalmologists, and others. And then finally, I do think future studies should expand the landscape of Mpox antivirals in clinical efficacy trials, especially in the most affected African countries in West and Central Africa. So data needs to come from this outbreak of what's happening now, and WHO is keen to support as best as we can with member states. So for example, here are a few important references. This is our Atlas of Mpox lesions, which has some really helpful photos, which we are currently updating. Here is our clinical management guideline, which also is getting updated shortly. And on the right is what we recently launched. This is the dashboard of Mpox clinical characteristics from the WHO Global Clinical Platform. Here, we will encourage you, if you're interested in participating in this, to email us, because we can help you create your own dashboard at your member state, at the country level, at the facility level, to understand the clinical characterization, the disease, and the risk factors for the Mpox patients you are caring for, so we can generate more understanding of the disease in this region. So with that, thanks very much for listening. Thanks, John and Jamie, for putting the slides together, and thanks to all the other clinicians that have increased our understanding and awareness of Mpox. Over.
Thank you so much, Dr. Janet, and really appreciative of the presentation, and also highlighting most of the most important aspects of clinical management of Mpox patient. I think the issue of and how holistic approach to patient management has come out very vividly, and also just optimization of standard of care as also coming up really quite well, and also just the aspect of reduction in mortality by half. That is 1.7% mortality compared half than the historical known mortality of Mpox using just the standardization of care, and this was proved in the PAM 007 study. So there we are, colleagues. We've had presentations from Dr. Caro, and we've had presentations from Dr. Rashida too, highlighting the epidemiological outlook of the situation. And then lastly, we've had also the presentation from Dr. Diaz, looking at the management and the holistic approach to management of Mpox cases. I'll see if I can try to open up the now for questions. I'll try to see if I can look at a couple of questions from the chat and ask maybe colleagues, panelists to respond to some of these questions. There's an interesting question actually that I would want to maybe direct to either Jamie or Dr. Dias in the chat. I think it's coming from Olivia. That is asking, how long do we isolate the patient? Maybe we can answer that in the live session. Either Jamie or Dr. Dias, you can take that one up. Over to you.
Thanks, John. So isolation of the patient. So at this point, the isolation is dependent on the evolution of the skin lesions. So when the skin lesion has crusted, it has desquamated, and then there's a fresh new area of skin that's grown on, which we call reepithelialization. That is when we consider the skin lesion no longer to be contagious, and the patient no longer needs isolation. So it is around the skin lesion evolution for full healing and reepithelialization of that lesion. Over.
Thank you so much. Yeah, and I think this came out really quite clear that it might take up to a period of 2 to 4 weeks for the lesions to completely heal and re-epithelialization. But maybe the more practical question, Dr. Dias, is, is it practical or is it really feasible to isolate the patient for the whole 2 to 4 weeks for the infectious period?
I think it depends on how much facilities you have. And this is why I do think it's really important to collect standardized clinical data at your facility. So talking to the audience here, John, I think, you know, when I was in DRC recently, I did ask what was the average length of stay for full healing of lesions, right, for reepithelialization, and they said about 7 days. So I do think it depends on the patients. Some patients may heal within 7 days. Others, you know, with much more complicated lesions may take, you know, longer time. And so it's a decision to be made on a case by case basis. I think if possible to remain to reduce any risk of onward transmission, keeping an isolation in the facility until fully healed makes sense. But let's say, you know, it's not possible. If patients have localized lesions, not all over, you know, not diffuse all over the body, but localized lesions that can be covered, you know, covered well with a sterile covering, and ensuring that it's not exposed if the patient was to, you know, travel back to home, you know, when they're in a place where they may be in closer contact with people, but as long as their lesions are covered, that may be acceptable. And then when they're home, to stay, you know, make sure that they continue to stay, you know, relatively isolated in the house until everything is fully healed. So that would be another option for case by case basis, depending on the extent of the lesions. Over.
Absolutely, and I think that's important also to just look at the simple practical infection prevention control measures that the patient can go with, and I think there was a question on the home-based care guidelines, and I just seem to lose who was asking this question, but the question was really direct to, I think, what Dr. Jamie and Dr. Rashidatu we've been discussing mostly around is it possible to practice the home-based care guidelines in an IDP camp with densely populated area with small tents where people are sharing these tents in one place? I don't know if Jamie or Dr. Rashidatu would you want to put a word into that? Yes, Dr. Dias.
Sure. Thanks, John. I think this is a extraordinarily important question, you know, and recently, like I was just in the Democratic Republic of Congo in Goma in the IDP camps, in those areas where displaced persons were being housed. And I do think it would be extraordinarily difficult to do home care isolation in a small tent that was housing 6 people or more than that. Because really, when you see the home care guidance that we will soon publish and have a webinar series on, you'll see that you still need to ensure some isolation area, even though it's not an isolated room, some isolated area where the patient can be cared for and be without contaminating other areas of the house. And I think that's complicated in IDP camps. What we have suggested is to ensure that in the IDP camps where there are increasing, access to primary care and other essential health services, to ensure that there's also a small capacity to isolate patients and care for patients with Mpox at those areas and those health points as well. So not make a different Mpox care pathway, but integrate it into the current, complex primary care services that need to be delivered in these IDP camps, but have a pathway integrated that includes Mpox, both at the health points within the camps, as well as the referral systems to the, referral hospitals where the more complicated patients would need to be cared for. Thanks, John.
Absolutely. Thank you so much. Yes, Dr. Rashida, I noticed your hand up.
Thank you very much, John. I think that's very clear from what Janet said. But again, looking at the volume of cases, especially in these IDPs, what we'll need to emphasize on is the prompt identification, prompt detection of these cases, and then prompt isolation of these cases. So that should be considered as well. Yes, the idea to have separate isolation units is very, very good. But then if we do not manage the situation in such a way that when these people start presenting with symptoms, they're carefully taken away from the crowd, then I think would have amplification of cases. And I think to bring into perspective other areas, this communication is very, very critical. So these are sort of some of the things that we'll need to take into consideration wherein we integrate the efforts of this response so that we'll be able to contain it timely before it would escalate beyond our control. Thanks, Inola.
Absolutely. Thank you so much. I want to turn to Caro if she can scan through some of the French questions, and then maybe we can give an extra 2 minutes. Maybe Caro, you can just scan through the French questions, and then you can air them out. And then I'll come back and maybe take 1 or 2 questions from the chat before I open up the discussion to the live questions for another maybe 2 minutes. Over to you, Caro.
Thank you, John. Il y a 2 questions qui sont presque similaires et je crois que
there are 2 questions that are nearly similar, and I think that Janet has already talked about it, the duration of isolation of the patients. We have already said that it is until we have a new skin. As John has said, that it could take 2 to 4 weeks, and it is the same question, that is, what is the time of contamination? It is relative. It could be 2 to 4 weeks, but it is until lesions are recovered. There was another question concerning R0. Some studies, and well, it depends on the different contexts. And in Europe, it's generally from 1.5 to 2.3. It is relative. I don't know whether the other speakers have answers concerning African region, but this is what we have for R0. I will try to see whether there are other questions, and I'll come back. Thank you.
Thank you so much, Caro. Really important. And also, before I open up to the live question, maybe for the last 2 to 5 minutes, I would just want to flag 1 question. I think that's coming from Dr. Tietina from Ethiopia. She's asking about the discharge criteria. I don't know if Jamie or Janet would want to take this one up. Over to you. Okay, so she's just asking about the discharge criteria. What could be the recommendations around the discharge criteria? Yeah.
When can we discharge? So I would try to consider both points. One is clinical discharge. So is the patient, better from their complications? Have you, what are the usual clinical discharge criteria you use for anyone who you hospitalize, and apply those as well. So that's one thing. And the second thing is, are they ready to leave isolation? And if they are, and that is the question about, are the lesions healed well enough, reepithelialized, so that you feel safe, you feel comfortable that they're not going to go out there and expose other persons to Mpox. Now, that is a different question. And that has to be done on a case-by-case basis. And again, as the colleagues have said, can take between potentially 7 to 3 weeks to 4 weeks. And again, case by case, if you want to discharge someone sooner, before the full lesion is reepithelialized, it would depend that there's only a few number of lesions that they can be covered, so that there's no exposure to others if they were to leave the isolation facility. But we'll make sure that these questions are more clearly described well in our future guidelines, as we have gained more, knowledge and information and experiences from the current outbreaks. Over.
Yeah, thank you so much, Janet. That's really an area that maybe will bring out a couple of questions through and through. And I think you've put it very rightly. We can always talk about the clinical discharge criteria. We can talk about maybe the clinical can have a subsection of the lesion criteria as well, and then you talk about discharge from isolation, which I think you've highlighted really, really well. And I think it will be good for us to look at this in the subsequent section and just give more clarity, like Janet has said. It's a very important aspect of this. There are some couple of comments, and I think Janet or Jamie would want to put a word to that. There's been some questions around, are there any studies going on in Congo DR looking at the Mpox outbreak, comparing it to the Ebola outbreak as well. Are there any, or maybe we could just have a word on what I think this is just highlighting the issues of, are there any clinical studies or any studies that are going on in this current outbreak? Over to you, Janet or Jamie.
Jamie, do you want to talk about the clinical platform?
Sure.
And then I can pick up on some of the other studies in DRC.
Yes. So I'll let Janet talk about the other studies, but there's a clear need to understand and characterize disease better. And that revolves around understanding the different clades and how they present, and particularly outcomes, and between those, all the important risk factors, because that will determine to some extent some questions around where patients are looked after, and that has large health system implications, and we don't really understand that at the moment. There isn't a uniform way of doing this, except we have the WHO Global Clinical Platform, and this has been used through the 2022 Mpox outbreak, and is now being revised so that it is relevant to this outbreak as well. It takes data, anonymized data from patients from anywhere we can work with. So that's ministries of health, from institutions, from NGOs, anyone who is allowed to give us anonymized data. And there are very strict terms of use and how we look after data, and how the original data are still owned by the people that upload it. All of that said, what we effectively want to do is bring together learning from multiple different, much smaller sites into a country, regional, and global whole. And if we get enough traction with this, I think we'll provide some really foundational data to really understand the outbreak from the patient's perspective, which is missing from the epidemiological data. I have put, and I will put the link in again for the global clinical platform, and it would be excellent if anyone who has access to data or who's thinking about collecting data uses what we have, our established pipelines, data, case report forms, analytical pathways, statistical analysis plan, and dashboards. All of those we can provide very quickly to you to help you understand your data and to bring it together as a whole.
Absolutely. I don't know, Janet, if you want to add something. Yes.
Thanks. Thanks, Jamie, and thanks, John. What I wanted to add is that in the Democratic Republic of Congo, there is research that's being coordinated under the National Institute of Biomedical Research, so the INRB. And I think that lead right now is Dr. Placide Mbala, and they are coordinating research. Now, what does that mean? I believe there is one ongoing study prospective in Kamitunga, and I think there's multiple partners involved in that study. We as WHO would like to, are trying to help support INRB and the MOH of the DRC to best coordinate any, studies in the future. But there is one that's ongoing that I believe is already recruiting prospectively. I don't know if any of the investigators are on this call. But it is important for the skin lesions, particularly WHO with partners are interested to update the skin atlas. And we will be sending shortly an expression for support, meaning looking for people to share with us their photography. Again, everything has to be done under strict, ethical, legal rules to collect photography with all sorts of approvals, so that we can publish it into our next atlas. But this is a piece of work that we're eager to engage in, so we're looking for partners to help us do that. But we'll be engaging through the normal circles, and then through the continental IMST. So that's the continental IMST structure between the WHO and the Africa CDC. There's also a research pillar there, meaning, and their work will also be to do some, light coordination around multi-country research protocols that relate not just to obviously vaccines, which is a major area, therapeutics, which is another area, but also I think, as described, the clinical characterization and risk factors. And we do hope that the clinical platform that Jamie described can be a tool that can be used in addition to other prospective studies to answer questions that the community has over.
Thank you so much, Janet. I noticed your hand, Dr. Rashida, too.
Yeah, thanks, Jonah. I saw a question on the chat box, which I think is very interesting, and I don't know whether colleagues Jamie or Janet could share maybe the experience on this with regards to anti-streptolysin or infections. Let me just be a little bit specific. Where is it? It's actually on the Q&A. Okay, it says Group A strep superinfection has always been a concern in pox virus infections. Are serological markers of this, such as ASOT, anti-streptolysin, and anti-dinase B, being collected in studies or in treatment centers collecting data? I don't know if we have any idea on this. Over to you again.
Jamie, do you have any insights on this?
I don't know about specific studies. I would have to look at the protocols. I do know that out with clinical infection, some of those things are very difficult to interpret. So what we really need to do is understand the rates of secondary infection as clinically diagnosed. That's really important. And some of the secondary markers, things that will help diagnosis and help differentiate the causes, for example, of a cellulitis or a neurosyphilis or something, then we can think about those. I will go back to the original trials and have a look at what they're collecting, but I suspect it's of secondary importance to their primary outcomes, and I doubt that we're going to get that level of information.
I agree with you, Jamie. It's really difficult to get some of the level, but I think it's a great question, and maybe we also something to look at in a Sentinel side and try to see if such level of detail and studies can be conducted as well. I see your hand, Dr. Rashidatu,
Sorry,
and please
hold
come
on.
through. Okay, legacy. Thank you. Okay, so I just want to take the maybe the last 2 minutes before I hand over to the Deputy IM from Africa CDC to give us the closing remarks, just to have any participant who has a question that they would want to ask in the live session, please just raise up your hand and I can notice you and open the mic for you to ask the question live. Okay, going once, going twice. Okay, all right. Okay, thank you so much. So I at this point in time, I would just want to give the floor to the Deputy IM for Mpox response from the Africa CDC side. And this is Professor Ndembi to give us the closing remarks. And maybe before that, let me just give a few announcements from my side, and maybe I can ask the colleagues from Project ECHO to give one announcement. So from my side is that thank you so much, and I just want to highlight that we envision this to be a series of 6 webinars, but we are going to communicate to you on the subsequent webinar dates and schedules through the emails that you registered. And the good thing is that since you registered for the first webinar, you don't need to register again. We'll just send the reminders and the topics and the updated topics. And also you are entitled to a certificate of attendance, and this will also be emailed. You can fill in on the link that is being shared as well. And we just want to thank everyone for the participation and also for the interaction. At this point in time, I would just want to invite Professor Ndembi to give the closing remarks, and over to you, Prof.
Good afternoon from Kinshasa. Thanks so much, John, and the team for really working so hard to really come up with a very well elaborate webinar series. We are really proud of you guys. Thanks to ECHO, other partners, my colleagues at Africa CDC, WHO, and others that are working on this. So I think for those that are not aware, it's a unified continental Mpox preparedness response plan. We're working with WHO, Africa CDC, and over 25 partners to be sure that we respond efficiently. This is the first time, it's historical, and we want to be sure we are successful. So there are 10 pillars I'm not going to go through, but case management is one of those pillars. I think we're making good progress there with the support of some of the experts Janet did presented, and my colleagues at Africa CDC that gave us a brilliant presentation. So I have a few points to close. We had a very good presentation on the AP situation, which is very good. We need to be sure that we provide the latest information. The clade 1A, clade 1B, clade 2, I think that was well illustrated. And we just want to be sure of coming to DRC that we're seeing already clade 1 and A and B co-circulating in the Kinshasa, the capital city. So it's showing that the virus is actually moving. I think we all agreed there's no boundaries for the virus. So that's what the discussion of clade 2 in West Africa, clade 1 in Central Africa. I think we need to do more on genomics, sequencing, and I can tell you from my history of HIV, the strengths are all over. I think we need to start moving to that discussion where we think the virus is just located in one area and that is it. No, people are moving, they move with the virus, and we've seen the cross-border surveillance the cross-border surveillance, which is supporting this data. We need more coordination, cooperation, collaboration, and communication across partners to be sure that we're successful, and we also engage the community. So there was a discussion around the guidance, both from the laboratory and on. So we need to start looking at differential diagnostics, because we've seen from the presentation, we're not only dealing with Mpox, we're dealing with orthopox viruses. So, and then there's a possibility, there's a possibility that we have some really misclassifications. And that conversation is extremely important when we start dealing with children, because we need to know the cause of mortality, and it's pretty high among those children. We're all talking about the strain, but we're not talking of the co-infections, what is actually killing, or actually responsible to the high, really, mortality. Another point around mortality is what we call healthcare seeking behaviors and associated factors. And we know that's not practical. You need to be on the ground to know this. Practical is that how our patients, what they go through before they actually enter the hospitals. They seek care to different levels before they go to at least the hospital. 11.9 will first go to the hospitals. Close to 54% will start self-based medication. All these are important. It means that when they get to the clinics, it's either too late, and that's why you have this really high mortality in some of the remote areas. So I think excellent presentation, and thanks so much. And we're looking forward to the next series. Back to you, John.
Absolutely. Thank you so much, Prof. And that's what we are looking forward to in the next sessions, to just go in details and look at what are the technicalities in management of skin lesions, technicalities in the presentation of oral, presentation of Mpox, and all the other nitty-gritties and aspects of Mpox management and also presentation. I want to thank everyone for joining us this afternoon, this morning, depending on where you are joining us from. And also just to thank the participants, the panelists, for a great session and interaction. At this point, I want to thank you all and wish you a very good day. Bye-bye from my side. Thank you.
Thank you.
Thank you so much.